Hello, Dr. Padmaj.
Hello, how are you?
Hi, nice to see you. Good, I'm good.
Yeah, I'm just making you co-host so that you can share your presentation.
Sure,
Yeah, so how are you doing? Busy?
I'm good. Yeah, busy. All the COVID's going on.
Good, yeah. All of us have become a COVID specialist. That's additional degree.
I know. Currently, we were just talking that we are having more COVID positive cancer patients than non-COVID positive cancer patients. It's getting to that stage.
I, I know. And in addition, we are handling COVID also. I mean, non-cancer COVID patients. So we got a bit more work than the usual one. You have to handle the cancer patients as well as the pure COVID patients because the
Right,
staff
yeah.
is exhausted. Yeah.
Yes, that we are getting those postings too. Yeah.
So I think it's 1 past 8. I think we should get going.
We start?
I'll start the recording. We are already live on the YouTube. Yeah, yeah. You can share the presentation. Once you share your presentation from your I'll introduce you and then we'll start.
Okay. Just give me a second. Can you see my presentation now?
Yeah, we can. We can. You can make a slideshow. Yeah. So let's get going. Uh, Good evening, friends. Today is again the IGMPO Talks, IGMP webinar series, which we have started early this year, sometime in March, and now it's become a routine for all of us to gather Tuesday evening 8 p.m. to listen to an expert talking about a specific and answering your questions. Today we have with us a friend and a colleague, Dr. Prasanth Ganesan, who is additional professor and head department of medical oncology, JIPMER, Puducherry. He is also part of the editorial board of Indian Journal of Medical and Pediatric Oncology. So, with this brief introduction, I hand over to Prasanth. Over to you, Prasanth. Please start your talk.
Thank you so much, Dr. Padmaj, for this opportunity. It's a great platform for all the students and also for any other practitioners. It's been a great series of lectures so far. I hope all the students have benefited from all these lectures as we have, and also it also gives us an opportunity to really review the core concepts in oncology and then prepare these presentations for you. So today I'm going to talk on adult acute lymphoblastic leukemia. This is a very wide topic. So what I'm going to do is I'm going to give you snapshots of some areas which I think are very important. I'm just going to touch briefly upon certain aspects which I think are important for the postgraduates to know from the exam point of view as well as from their practice, which they can and they should read up from good review articles. So I will give you important concepts which I think will help you in understanding this very complex disease. So I'm going to cover my talk in the following sections. One, I'll be dealing with the risk assessment. I will talk in detail about the current therapy of ALL, particularly with respect to the outcomes with conventional regimens. Why I'm going to stress here is that this is what we do day in and day out when treating these patients. Many of the newer drugs are out there and they're going to change the entire field of management. But at this point of time, at least for the next 10 years or so, we are going to be dealing with conventional regimens for managing ALL, at least in India. I will talk about MRD, which is a very important concept. I think you already had a lecture on MRD assessment about 2 weeks ago. So we'll just look at the clinical aspects of this. Then we'll just go into some details about the subgroups of ALL, like CD20 positive ALL, ETP, PH positives. Then in the end, I'll briefly cover about relapsed ALL, some things on newer drugs, and elderly ALL. I hope with this, I'll be able to give you an overview of the concepts in adult ALL. So starting with the risk assessment. Before we go into that, we must understand the prognostic status of ALL. So this is a very famous slide by Dr. Pui from the St. Jude's group, detailing the outcomes of pediatric acute lymphoblastic leukemia over the years. So as you see, from the 1966 to the current era, the outcomes in pediatric ALL has improved quite dramatically, from less than 10% to almost 91%. In fact, in one talk, Dr. P mentioned that they are not even bothered about prognostic factors in pediatric ALL to some extent, because almost everybody is cured. Unfortunately, we do not have that luxury when you talk about adult ALL. This is data from the MRC UCAL12 ECOG trial. I'll be referring to this trial quite often during my talk for various reasons. I'll explain to you in detail. In this, you can see that the adult ALL outcomes are definitely one half of what you will expect from the pediatric ALL outcomes. And as the age pushes up from the adolescent age groups to somebody who is over 50 years, the outcome comes down quite significantly to about 15 to 20%. As you grow older, the outcome is about less than 10%. So this is a stark contrast, and age remains the most important prognostic factor in acute lymphoblastic leukemia, and it is a continuum. Many of the adult ALL protocols use arbitrary cutoffs of 35 to 40 years, but they are truly arbitrary for the purpose of classification for a clinical trial. But definitely somebody who's over 60 years, at least from Western data, has a very, very poor prognosis. Where the cutoff lies for the Indian patients, we do not know. It's probably lower than that, but we know that above 50, 60 years, they do very poorly. Even when you use a similar protocol, the outcomes continue to drop. So it's not just the protocol. There are other reasons for this fall in outcome. And some people have described something called as a survival cliff in the outcomes of ALL. When, yes, it is a continuum drop in survival, but somewhere around the 15 to 17 years age group, the drop is quite stark, and it's like a cliff. And from that point onwards, then again, it starts dropping. So between 17 and 20 years, there is a dramatic drop in survival, probably due to biological reasons, which we will come to in the subsequent slides. But then the outcome continues to drop beyond that. So this is to understand the importance of age in acute lymphoblastic leukemia. Traditionally, other prognostic factors have been described, like the WBC cutoff, and again, an arbitrary cutoff of a T cell with a count of more than 100,000, and a B cell with a count of more than 30,000 has been used as a cutoff for determining high risk and low risk subgroups. But most of the recent trials seem to suggest that these may be actually surrogates for other prognostic factors. But yes, T cell more than 100,000 continues to remain a high risk factor for various other reasons. The immunophenotype, we will discuss that in detail. The gender, again, these are conflicting results in adult studies, but in pediatric studies definitely suggest that the male gender may have a poorer outcome, probably because of the higher incidence of testicular relapses. But in adult studies, this is not consistently seen. The central nervous system involvement at baseline has been shown to be a high-risk factor in many of the earlier studies, but recent studies do not show any impact on survival, probably because of some intensification of therapy, which does happen in many of the recent protocols. There may be other factors like the pharmacogenomic factors, the time to complete remission, the rapid reduction in blast cells. We talk about the day 8 blast count, of course, the MRD, and the time to completion of treatment. We will discuss some of these as we go along. How much of an impact does the cytogenetics make? This is one of the most important factors. We all know about the pH positive ALL. The survival is about 22%. Again, the data from the MRC ECOG trial. MLL gene. Now, this is positive in about 10% of adult ALL patients, and the survival is only about 24%. When you have a complex karyotype, this is again been described variously by various studies. Some people say 3 abnormalities, some people say 5 abnormalities. You have an incidence of about 5%. Again, the survival is 28%. High hyperdiploidy is a well-recognized good prognostic factor, and the survival in this condition is about 53%. All this compares to a survival of about 40 to 50% in a person with a normal karyotype. This is the survival curves detailing what I showed this. Now, what truly differentiates the adult ALL, again, this is a continuum, is the proportion of patients with these kind of abnormalities. The good abnormalities, like the hyperdiploidy, the 1221 or the ETB6RUNX1 abnormality, is distinctly overrepresented in the pediatric population. As you can see, almost more than half of the pediatric patients have these good cytogenetic changes, whereas in adults is less than 10%. Whereas the bad cytogenetic changes, like the pH positivity in a quarter of adult patients, only in 3% of the pediatric patients. The MLL gene, which is rearranged in 10% of the adults, it's only 3% in the pediatric, except in the infant subgroup where it's as high as 80%. Again, these poor prognostic factors, the low hypodiploid, near diploid, is almost 3 times higher in the adult populations. So overall, the biology is what clearly determines the difference in outcomes. Of course, there are other factors like the use of specific protocols, the tolerability, etc. As we talk about prognostic factors, you must understand that this is a continuum. Age from 1970 until now continues to remain a very strong prognostic factors, but others, as I mentioned, have gone on and off. For example, the immunophenotype is probably losing some of its prognostic relevance. Again, CNS disease I mentioned, what is the status right now? The cytogenetics has been recognized early and continues to remain a strong prognostic factor. But as we advance in our understanding, we are understanding more and more abnormal factors like the Icaros gene, the Notch1 mutations. These are also coming to be important prognostic factors. And now we have data from gene expression microarrays where we understand subsets like the PH-like ALL. I will talk about that in a minute. And minimum residual disease is, of course, one of the strongest prognostic factors in acute lymphoblastic. When you talk about prognostic factors, I think age, cytogenetics is what we currently use in practice. And these other things which are just going to come up in future. From the risk assessment, I will directly move on to current therapy and outcomes. And when I talk about the current therapy and outcomes, I'm going to detail one particular trial, which I consider as one of the most landmark trials in the context of adult ALL, which gives us a lot of information, gives us a lot of baseline from which we can really improve our understanding of this disease. So this trial is called the MRC UCAL 12 ECOG 2993 trial, one of the largest undertakings in oncology. This was also referred to by many people as the transatlantic trial because it involved patient enrollment both in the United States as well as in the United Kingdom. What this trial did was it randomized patients more than 18 years and patients with more than 35 years with these traditional WBC counts were considered as high risk. At that time, this trial started in 1993. It included pH positive patients also. The trial schema was something like this. These patients underwent induction, phase 1 and phase 2. After that, patients who had a sibling match, that is an HLA donor, were assigned to the sibling allogenic transplant. A mud transplant was allowed for the pH positive. Those who did not have a sibling donor or a match donor were randomized to an autograft or continuation of maintenance. This was a concept which is known as genetic randomization because whoever had a match went on to get an allogenic transplant. The understanding is that the probability of somebody having a match is a random event. So genetic randomization is almost, not completely, but probably not almost equivalent to a true randomization. So this tried to answer the question of whether we really need to do an allogenic transplant in CR1 in a patient with adult ALL. But as I will tell you, this is just one of the questions which was answered by this trial, because this was really a mammoth undertaking. There are much more questions which were answered from this trial, which serves as a baseline for all the future studies of acute lymphoblastic leukemia. As you can see, nearly 2,000 patients, adult patients, were entered in this trial, and 443 had a donor who were so-called randomized into the allogenic transplant arm. 588 patients did not have a donor, and they were randomized between autograft and consolidation or maintenance. However, the autograft arm was stopped after 119 patients because it was futile, and it was shown that there was no benefit of an autograft in acute lymphoblastic leukemia. This is another important contribution which came out of this trial. The induction protocol and the consolidation protocol in this trial, because you should understand this. The induction was a 4-drug induction standard with an ITMTX. And again, the second phase of the induction, again, fairly standard as we use for many of the current protocols like the BFM protocol. So there's nothing really here which was different from any of the pediatric protocols that we commonly administer. This was followed by an intensification phase with 3 cycles of high-dose methotrexate. Those who use the BFM protocol will be familiar with this kind of a model. Remember, all patients had the high-dose methotrexate before they were finally taken up for transplant. However, when it comes to the consolidation therapy, for those patients who did not undergo transplant, they had 4 cycles of chemotherapy, each lasting 28 days, in which they got some 4 to 5 days of Aracin etoposide in 2 cycles. The other cycles, they had various combinations of vincristine, dono, and cyclophosphamide. There was not a real phase of re-intensification like you see in the pediatric protocols. There was no further doses of L-asparaginase. So I would say this is where this protocol kind of loses its steam, and this part of the protocol is what makes this a true adult protocol. It really loses steam here because this is not dose intense at all. This phase was followed by maintenance phase. So this is what makes this an adult protocol. We will again discuss about what is pediatric and adult protocol. These are important concepts. What did this trial find? The overall survival of all the patients was roughly close to 40%, 39% at 5 years. This was 43% in the pH negative subgroup and 22% in the pH positive subgroup. Again, some important information which comes from this trial. For patients who did not achieve complete response, the survival was only 5%. If you achieve complete response at any point of time, even if you achieve complete response beyond 4 weeks after you gave the second phase of the induction, there was not much of difference in the survival, 46% versus 41%. What you understand from this? Achievement of CR is absolutely vital. It doesn't matter even if it takes some time to achieve CR. It's probably not as good, but it's at least better than not achieving a CR at all. The second important thing which comes out is the importance of age. This we already saw in one of my first slides. This is the outcome by various age groups in this trial. As you can see, there is a continuum, and as you grow older, the survival drops quite dramatically. So the important question from this trial, did the allogenic transplant in CR1 help? If you look at the relapse rate in the pH negative group of this trial, those who had a donor and probably went on to get the allogenic transplant, mind you, not everybody who were randomized to the allogenic transplant arm actually got the allogenic transplant, but this was an intention to treat analysis. So it was analyzed as such. What you can see is that the relapse rate was significantly reduced in the donor group who underwent an allogenic transplant. Almost it was half. So the allogenic transplant did its work in the standard risk patients by dropping the relapse rate by almost half. So it worked. When you look at the high risk subgroup, again, it does help. The relapse rate as high as 63% came down to 37%. Again, almost halving of the relapse rate by doing the allogenic transplant. Now coming to the primary endpoint, which was the overall survival, what happened here? If you see the donor versus no donor comparison, yes, there was an 8% improvement in overall survival. It is not as dramatic as the improvement in the relapse rate that you found. What was going on here? why is the overall survival improvement not as good as what you found in terms of the relapse reduction by the allogenic transplant? Was it the risk groups which were different? When you look at the high risk group and the standard risk group, what you find is the overall survival improvement in the high risk group was worth 35% to 41%, which was not significant. P-value was 0.2. Whereas in the low risk group or standard risk group, it was improved by around 10% and the p-value was significant. Remember here, the high risk and the low risk was determined primarily based on age, less than 35 versus more than 35, and also to some extent based on the WBC counts. What was happening here is a very high treatment-related mortality. At the end of 2 years, in patients with high-risk disease and who had a donor, that was assuming they all went for an allergic transplant, the TRM was as high as 35%. That means an older person, when he goes for a transplant, he is at high risk for a transplant-related mortality. And a standard risk patient, when he goes for a transplant, the mortality is still very high, but it's not as high, it's around 20%. Whereas the no donor group who underwent standard therapy, the TRM was only about 6 to 7%. So whatever benefit the reduction in relapses which was brought about by the allogenic transplant was lost because of the very high TRM, especially in those who were over 35 years. What are the lessons that we learned from this very important, very large and well-conducted trial is that in adult ALL, the standard so-called adult type protocol has a chance of a 5-year overall survival of about 40%. If you are low risk, that is below 35 years and with standard WBC counts, you may get a survival of close to 50%. However, if you are high risk, your survival drops to around 30 to 35%. Allogenic transplant helps in reducing relapses, but at the cost of increased TRM. So this trial concluded that the allogenic transplant may benefit those in 18 to 35 years age group, but does not benefit those who are more than 35 years. If you are not in CR after 2 courses of induction, whatever you do, your survival is quite dismal with conventional therapies. In this trial, pH positive subgroups who did not get imatinib, the survival was only about 22%. So to transplant or not in CR1, there is a conundrum from this trial. Somebody who is less than 35 years in standard risk, yes, they do benefit. Somebody who is more than 35 years in high risk does not benefit. But again, remember, this is when compared to an adult type protocol. So what happens when you use pediatric regimens in adolescent and young adults up to 40 years of age? Many people do not treat a young person up to 35 years of age, like in the UCAL protocol, with an adult type protocol. Most people are going to use pediatric type protocols. When you use pediatric type protocols, as in the CalGB data, here they included patients up to 40 years. What they found was the 3-year overall survival is 73% with a very low TRM of only 3%. Similar data from the MD Anderson Cancer Center using something called as an augmented BFM, which is your traditional BFM with some extra less paragenase and intensification of the cyclophosphamide doses in the consolidation. Again, the survival was as high as 60% at 5 years, which is much more than what was presented in the UCAL data. Of course, this intensification comes with its own problems like pancreatitis, hepatotoxicity, and thrombosis, but the overall survival is still very good. So, again, some more data with the unified protocol of this NOFO group, which is again a pediatric protocol. There is drop in survival as you grow up in age. However, in the 18 to 45 years age group, they were able to demonstrate survival as high as 74%. This is just a summary of various AYA ALL patients treated with pediatric type protocols. As you can just look at the last column here, the overall survival well over 60 to 70% in many of these trials. Of course, the age median ranges from 20 years to 25, 26 years. So young people, but excellent survival. So definitely, there is no indication for an allogenic transplant as was shown by the UCAL trial when you are using a pediatric type protocol. This is our own data from the Hematology Cancer Consortium. About 9 centers got together, pooled our data, of nearly 1,400 patients of adolescent and young adult ALL. The median age in this study was 20 years. We included patients from 15 to 29 years, and about 28% were high risk by the WBC count. And the 2-year EFS in this study was 64%, and it was slightly better when patients got a pediatric type protocol. Among the BCR-ABL positive group, the survival at 2 years was around 52%. Slightly early data because the follow-up was not extremely long. But again, reassuring data that a pediatric type protocol is doable in our country and gives very good outcome, at least in young people. So what is the difference between this pediatric protocol and the adult protocol? You must remember, before we go into these details, that there is a lot of overlapping features in many of the protocols. So some of them will be a very strict adult protocol, like the earlier versions of the GMAL protocol, which some of you may be using in your centers. But many of the recent protocols, including the UCAL protocol, which I showed you, has very many components which may mimic other pediatric protocols, but there may be some areas where they lose the intensity and they may be classified as the so-called adult protocols. But for your understanding, what this means is that in a pediatric protocol, generally the corticosteroid doses are higher per meter square when you calculate. There is a cumulative dose which is higher. And generally, they introduce dexamethasone at some point of time. And because of the higher activity, higher penetration, again, this comes at toxicity of its own. There's definitely higher intensity of vincristine. L-asparaginase, one of the most important drugs in the pediatric protocols, which is very strongly represented in terms of the number of doses. Even when using something like PEG L-asparaginase, the number of doses, the higher cumulative dose is very evident when you're using pediatric type protocols. However, this is an important consideration in adults because L-asparaginase, most of the adults do not tolerate it very well. The next thing is the antimetabolites like the methotrexate, cytarabine, 6-thiopurine, 6-mercaptopurine. Generally, higher dose methotrexate is preferred in the pediatric protocols. The UCAL was 3 gram per meter square. Most of the BFM protocols for T cells use up to 5 gram per meter square. There is generally lesser use of anthracyclines in pediatric protocols. They will tailor the use of anthracyclines for low-risk patients. They'll avoid or lessen the number of doses in the induction at least because of concerns regarding myelotoxicity as well as cardiomyopathy in young children. IT chemotherapy is intensified. Many of the pediatric protocols completely avoid the cranial radiation. So these are some of the important conceptual differences between a pediatric protocol and the adult protocol. But again, remember, if you take an individual protocol, there may be overlapping features. It may be difficult sometimes to label a protocol as adult or pediatric. Many of these protocols are modified or adapted for individual centers. So you must keep all these in mind when you are deciding on where your protocol fits in. Again, CR1 allergenic transplant is based on an MRD-based strategy in most of the pediatric protocols. So definitely more intensive, definitely gives a better result. But remember, more intensive is definitely more toxicity. This is again data from the St. Jude's. You can see that grade 4 to 5 infection was as high as 12%, osteonecrosis in 1/3 of the patients, thrombosis in 1/4 of the patients, and hyperglycemia in 28% of the patients. This is when a pediatric protocol, very intense pediatric protocol, was used in an adolescent age group. You can imagine when we start extending this to patients who are 30 years or 40 years or 50 years. So this is, again, data when pediatric protocols are extended up to 60 years. There was significant increased toxicity reported by the GRAL group, but the UCAL 14 group showed a dramatic 18% treatment-related mortality during induction therapy. And they said that there was a 10-fold increase in death in patients who are more than 40 years when you're using very intense protocols. So caution is very important. You cannot escalate therapy without considerations in older people. You must look at their fitness. You must look at their comorbidities before you decide, yes, I'm going to put a 50-year-old on a BFM protocol. This is data from CMC Vellore. where they compared their data with the traditional adult GMAL protocol and a more intense hyper-CVAD protocol. Hyper-CVAD is not your traditional ALL protocol. It misses many of the usual components like L-asparaginase, but it has shown excellent outcomes in specific centers like the MD Anderson Cancer Center. And many people consider this as a standard protocol for adult ALL. However, in CMC Vellore, what they found was that patients who were treated with the GMAL protocol actually did much better. This is because of the high non-relapse mortality rate in hyper-CVAD because of the toxicities. Again, data from Cancer Institute, where BFM 95 protocol was compared with other protocols, mostly GMAL type adult protocols. And as you can see, the induction deaths was as high as 10% in the BFM compared to 1% in more less intense protocols. And overall toxic deaths were also increased when you use BFM. This, again, remember, this is slightly older data. As you start getting used to a protocol and you're comfortable with the protocol, your TRM will start coming down. So that is an important consideration. And so the important thing here is to go slow. So maybe if you're starting off for the first time trying out a pediatric protocol in an adult age group, it'd be a good idea to start with somebody up to 25 or 30 years. And as you grow comfortable with the protocol, then you can extend up to 35, 40, or even 50 years, choosing your patients very wisely. So this is the most important message here. There are also center-specific issues, supportive care, high-dose methotrexate. Are you able to give beds whenever a patient becomes sick? In the current time of COVID, you must have those considerations in mind when you're putting somebody on very intense protocols. Infections are just definitely going to be higher. Availability of beds for high-dose methotrexate in some of the government centers. So all these issues need to be considered. And remember, even in the United States, where all this data is available, even in the United States, at least up to 2014, when you look at the data, many of the AYA ALL patients continue to be treated in adult settings with adult protocols. As high as 1/3 of the patients do not get treated in pediatric settings or in pediatric protocols. So there are challenges across the world, despite very strong and compelling data that AYA ALL patients are better off with pediatric therapy. So we can safely conclude that an allogenic stem cell transplant in CR1 is not required in AYA ALL patients when using pediatric type protocols. If you're talking about more older patients, not strictly an adolescent or young adult, we have data from the MRC UCAL ECOG trial that the higher TRM obscures or eliminates whatever benefit you get from reduced relapses. Now, what about high-risk patients who are otherwise defined? So we have data on allo-ACT from the GRAL group, where they looked at only high-risk patients, which were defined by various criteria like cytogenetics, the blast percentage, the WBC. They used a mix of criteria to determine the high risk. In this study, the median age group was 31 years, some kind of a genetic randomization for these patients. And patients who had a donor went on to get a stem cell transplant. Without donor, about 240 patients. This is not a strictly a randomized trial. This is more like a comparison of the data from their two consecutive prospective studies. What they found was that even after balancing for age, there was no benefit for allogenic transplant in CR1 when you're using a protocol like GRAL, which is a true-blooded pediatric protocol. There was, they again found that there was benefit in reducing relapses, but this was counterbalanced by increased TRM. So as such, transplant versus no transplant, no benefit. So is there an adult ALL who should get allogenic transplant in CR1? Again, from the GRAL study, we had a data on MRD. This data was not available from the MRC UCAL trial. Patients who are MRD negative, who did not get allogenic transplant, MRD negative who got allogenic transplant. These two dashed lines, as you can see, there was no difference. So if you have MRD negative, it doesn't matter whether you get an allogenic transplant or not, the outcomes are same. If you are MRD positive and you get an allogenic transplant, your outcomes are much better. But if you're MRD positive and do not get an allogenic transplant, your outcomes are very bad. So the subgroup of MRD positive are the ones who definitely benefit from allogenic transplant. This is one important message which came out from the GRAL study. So decision should be based on MRD, not based on baseline risk factors. This is again data from similar kind of patients. These are truly adult patients because the median age in the PETIMA ALL HR1 trial was close to 40 years. Again, a similar concept here. They looked at MRD after consolidation, taken MRD of 0.01% as the cutoff point. Here, the median age of 40 years, what they found was a 5-year overall survival of 48%. And those who were assigned to transplant, it was 38%. Chemo alone was 55%. So as such, there is no benefit for the transplant. But those who are MRD positive, they benefited from the transplant. If you are MRD negative, avoiding an allogenic transplant does not hamper the outcome. So we'll just move on briefly to look upon the MRD data in adult ALL. This is an important meta-analysis of all the MRD data. Summarizing the whole thing, when you look at the adult as well as the pediatric, you can clearly see once you are MRD negative versus MRD positive, there is an almost 30 to 40% difference in the outcome at the end of 10 years. So MRD currently can be said as the most important prognostic factor in acute lymphoblastic leukemia, whether it's adult or whether it's pediatric. So there's a whopping 40% difference in outcome. So clearly an area where you can intervene even with a high risk intervention like allogenic transplant and produce a difference in outcome. You must all be familiar with this concept. So when you achieve something called a hematological remission, there is significant proportion of tumor cells in the body because you are MRD positive. But if you are MRD negative, the tumor cell proportion comes down significantly when it is below 10⁻⁻⁴, which is the usual limit of detection with flow cytometry based MRD techniques. With PCR, you can go down further. You can go up to 10⁻⁵, and with modern NGS based MRD techniques, you can go up to 10⁻⁻⁶. So these are deeper and deeper levels of MRD, but traditionally most trials use a cutoff 10⁻⁴ or 0.01% when you're taking cutoff of MRD, especially at the end of induction. Now, one other question remains. For a patient who is MRD positive, can we just get away with higher doses of chemotherapy like some of the pediatric protocols do? Or should we always do an allogenic transplant? Unfortunately, we do not have definitive answers to this question at this point of time. There are some studies which are not truly randomized studies, but there is some data from some of these studies which does suggest that a high-dose chemotherapy and a stem cell transplant might have similar outcome. But again, remember, these are small studies, so we do not have data at this point of time to be very strong about this. So at this point of time, we would just conclude that allogenic transplant remains standard of care for a patient who is MRD positive if they have a matched donor available. The second thing which emerges from some of the patients is that even if they have high-risk disease at baseline, if they become MRD negative, their outcomes are very good, irrespective of the baseline high-risk status. So should we transplant all MRD positive adult patients with ALL? The pros is that allogenic transplant reduces the risk of relapse across multiple studies. The cons, ERM is still high, 50 to 30%, and patients have to contend, at least half of them have to suffer significant chronic GVHD over their lifetime. Again, remember, there are no randomized trials comparing intensive chemo versus allogenic transplant in MRD positive patients, but we have enough data from multiple studies to suggest that an allogenic transplant benefits MRD positive patients. So again, the decision making should be also based on type of donor. If you have a matched sibling, you are more prone to do the allogenic transplant. The center experience, if you have a center which can claim less than 5% TRM with a haploidentical transplant, then that center is justified in doing a haploidentical transplant for an MRD positive patient. But if your haploidentical transplant mortality is as high as 40%, then definitely not the choice for somebody who is MRD positive. So these are other factors which play in your decision making. The age and comorbidities, of course, will always determine your transplant outcomes. So it's a more of a nuanced decision. Aside from all these scientific considerations, there are other smaller things which we tend to ignore when you're treating a patient with adult AL. And adult AL treatment from the patient perspective is not a simple undertaking. It's not like you walk in the park, you come and you finish your treatment in 4 months and 5 months and you get out of it. It requires a lifelong commitment. It requires a very intense commitment for at least for the 6 to 8 months, and then again 2 years of maintenance. So there are significant proportion of patients who have non-adherence or abandonment with treatment, and this is higher in the adolescent and young adult age group. So maybe as high as 15% in some of the studies. And from the HCC data, we have abandonment in as high as 12% of patients of AYA-ALL from India. And again, delays during the intensive phase due to various reasons. We may not have beds, the patient's not coming on time, there may be toxicities. So remember, when you have delays, the intensive phase of treatment is ideally completed within 6 to 7 months in something like the BFM protocol. If it goes beyond 9 months, the relapse-free survival drops significantly to 43%. But if you complete it on time, your survival is much better. This is again data from a cancer institute which was published. So important to keep the timelines very tight, use all the supportive care that's possible, and try to complete your treatment on time. This is a very important consideration and a simple thing to do without any fancy drugs, how you can improve the outcome in a patient with a young adult ALL on intensive protocols. So to summarize the treatment protocols again, prefer pediatric protocols as much as possible, at least up to 40 years. And if you're capable, you can push it up to maybe 50 years. Allergenic transplant in CR1 is currently reserved for those who are MRD positive. Maybe very high risk subsets like MLL alterations, pH positive ALL, you can still consider allergenic transplant in CR1. There is no one pediatric protocol which is compared to another and shown to be superior to another. So again, here it's important to use whatever a center or a person is comfortable with, build your own data and experience, and try and deliver whatever you are delivering well. Beyond 40 years, whatever you do, the conventional approaches, the results are generally poor. So important to keep other things in mind. So what else can you do to improve the outcomes? One of the important things is to subtype and see whether in some particular subtypes you can do something better than what you're doing at this point of time. Or at least understand that these people are not doing so well. Maybe you can do something better in future. One simple, straightforward thing is the CD20. So CD20 expression of more than 20% is traditionally defined as CD20 positivity in leukemic cells, and this can be seen in about 1/3 of patients of acute lymphoblastic leukemia. Earlier studies showed that CD20 expression is a poor prognostic factor in BALL. And again, the CD20 expression is not just one on-off, it is also a continuum. So even within the above 20%, there may be somebody who is just expressing to somebody who has got a very strong expression in almost 100% of the blast cells. So there is a wide range here, but again, by convention, anything over 20% is considered as positive. So this is the landmark study by the GRAL group in adult ALL. They use their traditional GRAL protocol, which is a pediatric type protocol. In this study, they randomized patients to conventional chemotherapy versus conventional chemotherapy plus rituximab. In this trial, rituximab was delivered in 16 doses, 2 of them during induction, 4 during consolidation, 2 during late intensification, 2 during late consolidation, and 6 infusions during the maintenance phase. They could clearly show an improvement in EFS as well as overall survival with the addition of rituximab to conventional protocol. So this is something which is eminently doable by many of the centers because rituximab is available as generic and can be added to your protocol without a huge increase in toxicity. The question still remains whether when you are using a pediatric inspired protocol, because pediatric protocols do not traditionally use rituximab, should we still add rituximab? Yes, because the GRAL protocol is similar to a pediatric regimen, even though there was no high-dose methotrexate use. The L-asparaginase doses were quite high. So you must still consider using rituximab even if you're using a pediatric type protocol. How many doses? Do we really need 16 doses? We do not know. There are no other studies which have really compared the GRAL regimen with the other regimens of rituximab, and which component of therapy should be included in your particular regimen that you're using. These are unanswered questions. But yes, do consider including rituximab when you're treating BALL if they are CD20 positive. Coming to the Tcell ALR, should we look at it differently? Older protocols have, in that older mean really older protocols have recognized the Tcell as a high risk factor. But newer protocols, especially those who incorporate some amount of methotrexate, either as high-dose methotrexate or as Capizi in the pediatric age group as well as the adult age group, have clearly shown that the T cell does not stand as an independent prognostic factor. Having said that, the pediatric protocols, at least the current understanding is that it's a very tailored approach. So whenever you have a T cell, there are some things which you do. One, you must prefer an early treatment intensification. So something like an augmented BFM, additional dose of L-asparaginase do help in a pediatric in a T-cell ALL. A 4-drug induction is a must. There is no chance of getting away with something lower than that. Many studies have shown that use of dexamethasone improves survival in T-cell subgroups. There is data, strong data from pediatrics protocols that nelarabine improves the DFS in T-cell ALL. Whether you should use a Capizi or a high-dose methotrexate, the data is controversial. In some of the COG protocols, the Capizi was actually superior to the high-dose methotrexate. But again, this is all very confusing because the Capizi arm also got additional nelarabine. So we do not know that clearly yet. There are other studies which show that the high-dose methotrexate is actually better. Again, the allogenic transplant consideration is based on the MRD. This is the data with nelarabine, which shows that addition of nelarabine can improve the outcomes in T-cell ALL by about 5 to 6%. There is this concept of early T precursor ALL. I'm just touching upon this because I think this is important for all postgraduates to understand, because for your exam purposes, and also this is an entity which is being increasingly reported because we are using extensive flow panels for the diagnosis of leukemias at this point of time. This was recognized in after 2010 and put as a separate entity in 2016 WHO classification. It is recognized by the expression of early T-cell and myeloid markers, markers like CD34, CD117, 13, 11B, HLA-DR. However, the MPO is always negative, and also a characteristic phenotype of CD1A negative, CD8 negative, and CD5 weak positive. When you have this, this is how the pathologist makes the diagnosis of early T precursor ALL. It is supposed to originate from the cells which are just migrating from the bone marrow to the thymus. It has been understood that this subgroup has higher chance of positive MRD and also higher chance of not going into remission at the end of induction. The MRD positivity rate may be as high as 70 to 80% in some of the studies. Also enriched for certain unusual mutations are not usually found in other types of TALL. But outcomes of ETP ALL, is it always bad? It seems to depend on the type of protocol used. The MD Anderson Cancer Center showed that when using hyper-CBAD, ETP versus non-ETP TALLs, the ETP had significantly worse outcome, about 40% versus close to 60%. However, in pediatric protocols, which use other agents like nelarabine or some forms of high-dose methotrexate, no difference was found with respect to ETP ALL versus other ALL. The current consensus is that we do not really treat it differently. You recognize it as a poor prognostic factor. But what can be done is an MRD-based transition of protocol, probably consideration of allogenic transplant in patients who are MRD positive should be strongly considered. And the rest of the protocol as such does not change for a person with ETP ALL. I'll quickly complete this concepts on pH positive ALL. Let me just quickly go on to the UCAL protocol. The UCAL protocol had a slight modification in 2003 when imatinib was added to the induction, and 2005 when imatinib was added to the consolidation. So they could compare this data of the imatinib versus the pre-imatinib cohort for the pH positives, and they could show that yes, imatinib clearly improved the outcomes in pH positive ALL, and earlier you use it, the better it is. So early imatinib had outcome of close to 39%, whereas the pre-imatinib cohort had only about 19%. So I'm not going to go into great detail, but these are the various studies which have incorporated TKIs into various regimens for adult ALL. The age groups you can see here. For very old people using simple regimens with steroids and TKIs followed by some amount of chemotherapy, you can still get survival of over 45 to 50%, which is much better than what you got with the UCAL protocol, which was only about 20%. So TKIs have dramatically improved the outcomes of Ph positive ALL. Similar data from many other studies, survival ranging from 40 to 45%. Again, the allogenic transplant was still continued in all these protocols, except the MD Anderson study where they used hyperCVAD, the allogenic transplant was done only in about 30%. Some studies have shown that auto transplant in patients who are MRD negative gives as much benefit as an allogenic transplant in Ph positive ALL. This is the data from COG, which is traditionally quoted for avoiding allogenic transplant in Ph positive ALL. This is a pediatric study, the median age of 10 years, where they used imatinib plus intensive chemotherapy, and they found without an allogenic transplant, still you had a relapse-free survival of 70% at 5 years. Of course, this is pediatric data, not really recapitulated by the adult studies. So we cannot directly extrapolate, but yes, interesting data that you may still get away without an allogenic transplant for Ph positive ALL. The role of very intensive induction was studied by the GRAL protocol, which was a randomized controlled trial of Ph positive ALL, where during induction, they randomized them to intensive chemotherapy versus low intensity chemotherapy. Low intensity chemotherapy was just vincristine, prednisolone, and TKI. And they found there was no difference. The complete molecular response rate was similar. So you can get away with low intensity chemotherapy and avoid all the toxicities and mortality during induction. In fact, just by using vincristine, prednisolone, and steroids without any daunorubicin or a lasparagine with imatinib, you can get almost 95 to 100% complete response rate in Ph positive ALL. Again, this trial also showed that in those who do not have a match, the auto transplant gives the equivalent outcome to allogenic transplant. So this was an important randomized trial in the context of Ph positive ALL. Coming to dasatinib, again, a lot of single arm data with dasatinib. This is from the pediatric age group, the COG, showing excellent RFS and OS at 5 years with the addition of dasatinib. Again, MD Anderson Cancer Center has combined it with hyperCVAD and shown excellent outcomes. Similar data from the US intergroup showing excellent outcomes at 3 years, almost 60 to 65%. This is data from the European ALL group in patients who are older. The median age here is 69 years. Again, low intensity chemotherapy with dasatinib, survival of close to 36% in a very old subgroup of patients with Ph positive ALL. More recent data with ponatinib from the MD Anderson Cancer Center group with intensive chemotherapy and ponatinib. That intensive chemotherapy is hyperCVAD. The CMR rates are very high, 78%, and early data showing overall survival of 80% at 2 years. The allogenic transplant was done only in 24% here. So again, you can get away without an allogenic transplant when you're using newer drugs like ponatinib. And data in older patients with ponatinib and steroids showing excellent outcomes at 1 year. Very early data at this point of time, but very provocative data. So this is the data of hyperCVAD plus ponatinib in Ph positive ALL. So these patients had 8 cycles of hyperCVAD and ponatinib. The ponatinib was initially given at 45 milligrams in the first cycle, and later on it was amended, and the dose was reduced to 30 milligrams from cycle 2. And those who achieved CMR, the dose was reduced to 15 milligrams. This amendment was done because of the high cardiovascular toxicities of ponatinib when it was used continuously at 45 milligrams. And the maintenance was continued for 2 years. Allogenic transplant was allowed only for match donor at the discretion of the treating physician. And as I mentioned, only 20% had allogenic transplant in this protocol. Excellent 3-year EFS, overall survival, and relapse-free survival. And those who achieved CMR at 3 months, the survival at 3 years was 81%. Of course, you had toxicities with the intense protocol as well as the ponatinib. Infection rates were high but manageable, and the TRM was 6 out of 76 patients. Remember, 2 patients died due to acute MI due to ponatinib 45 milligrams. But this came down after they changed to lower doses of ponatinib. So these are the curves from this trial. Again, you can see here those without an allogenic transplant still had an excellent survival here. And probably this indicates that if you are using something like ponatinib, you can get away without an allogenic transplant. Just to summarize the data of Ph positive ALL, should everybody really receive a transplant in CR1? Yes, when there is a matched donor available and the risk of allogenic transplant is fairly low, it remains the standard of care. Pediatric data says you can avoid transplant, maybe an option in younger patients or when you are using something like ponatinib. Can MRD negative avoid a transplant? You saw the data from the MD Anderson Cancer Center with ponatinib. Yes, in those patients, when you're using intensive treatment with something like ponatinib, if you're MRD negative, you can avoid doing a transplant. How long to continue the imatinib? In post-allo transplant settings, many trials use it for 2 years. We're not doing allogenic transplant, possibly lifelong. We do not have any answers to this question at this point of time, but this is what most people do. Should we really continue TKIs after allogenic transplant? There are data both for and against it. There was actually an attempt at doing a randomized trial by the GMAL group. They did suggest that there was no difference in the leukemia-free survival. But again, this was a very small study. So the data is not very conclusive. There is data from retrospective data like the ESMBT, which suggests that prophylactic imatinib, instead of waiting for some MRD positivity and then starting, prophylactic imatinib is actually better to improve the leukemia-free survival. So currently, yes, after transplant, you should start TKIs as soon as possible. But some of them may not be able to tolerate something like 100 milligrams of dasatinib. So you probably have to do with something like 50 milligrams of dasatinib if they are not able to tolerate the full doses. Whether you should use full intensity, the GRAL RCT has clearly shown that there is no need for a full intensity induction. The complete molecular response rates were similar, whether you use a full intensity or just use incretin steroids and TKIs. What about elderly unfit patients with Ph positive ALL? Use TKI with minimal chemotherapy, avoid induction mortality, you get almost 100% CR with this combination. However, the remissions are not durable unless you consolidate with further chemotherapy. Allogenic transplant may not be an option in this age. Just a couple of slides on this concept of pH like ALL. Again, I'm just touching upon this because it's important from the point of view of exams, a favorite question in many of the theory papers. Remember, this concept of pH like ALL is derived from the gene expression profiling. So this is a subgroup of acute lymphoblastic leukemia, which has got a gene expression profiling, which is similar to BCR-ABL positive ALL. When they did the profiling, this was an important paper in the New England Journal of Medicine. They found some characteristic abnormalities in this subgroup of patients. They found there are groups of patients with ABL class fusions, the JAK2 mutations, CRLF2 alterations, and other alterations in the JAK-STAT pathway. So some characteristic abnormalities are reflected in this group of patients with pH like ALL. What was interesting is that the pH like ALL group had an inferior survival. As you can see, the children have got a survival of only about 60%, whereas traditionally they have a survival of 80 to 90%. And even adolescent and young adults also have inferior survival if they have a pH-like phenotype. How common is it? It's about 10 to 15% in children, but it goes to as high as 25 to 30% in the AYE age group. Some studies have suggested some racial predispositions for the occurrence of the pH-like AL. The challenge is the diagnosis. So it has been traditionally described based on gene expression profiling, which is not, as you know, practically doable in the clinical context. So if you really want to recognize pH-like ALL, how do you do? One usual thing is to identify the rearrangements of CRLF2, probably by FISH, or as a surrogate, you can look at CRLF2 expression by doing immunophenotyping. Again, 50% have JAK1 or 2 mutation, which can be assayed by using PCR-based assays, and the other rearrangements can be looked for by using PCRs or by using next generation sequencing. So there's no easy way out to diagnose a pH like ALL, but yes, it's an important consideration. And here you can see the outcomes of pH like ALL versus the non-pH like ALL. You can see a clear difference in the outcome in the CALGB data. And the CRLF2 positive subset of PH like ALL, which is almost 80% of the PH like ALL, these seem to have the worst outcomes among all the PH like ALL. This data from the MDR case. So in practice, the first step would be to do a flow cytometry for CRLF2. This is an antibody which is easily available, which can be incorporated into the flow cytometry protocols of many centers. However, this is the easy first step. And remember, just by saying the CRLF2 expression is there in flow cytometry, straight away it doesn't become a PH like ALL. It's only an indication. You must confirm that the CRLF2 alterations exist by doing specific PCRs for CRLF2 mutations or FISH studies to determine the translocations of the CRLF2. The further studies for PCR and NGS for JAK2 mutations can confirm the occurrence of a PH like this thing. Again, remember that all these things in the context of PCR radial negativity only. If you have further fancy stuff like the NGS available, there are fusion panels, NGS panels which are available, which can determine the PH like ALL currently available in academic centers in the West. Again, FISH for specific abnormalities like ABL1, JAK2, PDGFR1, CRLF2 can also be done to determine. It's a combination of things. Various algorithms have been developed which can give you an idea that this particular patient is having a PH-like phenotype. Maybe worth considering in somebody who is adolescent or young adult, because 1/3 of them can have this PH-like. What do you do when you find it? At this point of time, this concept is only in clinical trials, but because they strongly exhibit these kind of kinase mutations, and they are targetable with various TKIs. So you can use dasatinib for some of these mutations. JAK2 inhibitor can inhibit the JAK2 pathway alterations. And of course, other alterations, some people have actually MET or ALK mutations. You can use crizotinib. So these kind of options are available, but data is very limited at this point of time. So this is all probably going to emerge in the future. They have a high rate of MRD positivity, so you may try to use blinatumomab to eradicate the MRD. I will talk about blinatumomab in this context in the next section. So this is, so far we looked at the risk assessment. We talked about standard therapy of acute adult ALL. And we also talked about some of the specific subgroups like CD20 positive, Tcell ALL, ETP ALL, PH positive ALL, and PH like ALL, and how to manage these subgroups, recognize these subgroups. And here we are going to look at relapsed ALL. So one thing to remember is what happens to patients after they relapse. Again, we go back to the MRC ECOG trial. Once they relapse, the outcome is very, very dismal. Long-term survival of relapsed ALL is 7%. This has not really changed. In patients who do achieve a CR2, it may be slightly better. It may come up to around 10%. But if they do not achieve a CR2, your survival is less than 10%. So very, very dismal outcome once they relapse in adult ALL. So this is slightly older data. Is the newer data any better? This is data from the German groups. If you have a CR with one salvage, your outcome goes up to 40%. With second salvage, 21%. Third salvage, 11%. So maybe some slightly better data from the German groups. Your survival. No, sorry, these are the CR rates. These are not actually the survival. I'm sorry. The survival is still not very good. If your first salvage is about 11%, second and third salvage, it's quite dismal. And again, if you do not get a CR at all, it is almost nil. So even the more recent data does not sound very optimistic. Once you relapse, you are really looking at a very bleak future in acute lymphoblastic leukemia. So with conventional therapy, you're not going to achieve much once you relapse. So we look at newer drugs. Again, I'm not going to go into great detail, just to touch upon some of these newer drugs because they are important for postgraduates. We do not have many of these drugs in hand. So we are this discussion becomes mostly theoretical at this point of time. There are four main drugs which are available for relapsed ALL, which have significantly impacted the outcome. One is blinatumomab, as you know, bispecific antibody. Inotuzumab ozogamicin, which is an antibody drug conjugate to CD22. You have the CAR T cells, and then you have some very interesting new data from venetoclax. It's interesting because venetoclax is something which seems like we can access at this point of time. So the blinatumab showed some improvement in the phase 2 study. I'm really going to go fast here. The phase 3 trial, the landmark trial was the tower study in very heavily pretreated ALL, as high as 3 to 4 lines in some of the patients. What they showed was MRD negativity 76% versus 48%. The median overall survival was improved, not hugely so, but still it was statistically significant. So some activity was shown, and these are the survival curves. But again, remember, this is very dismal group of patients where it was studied. But the children's oncology group actually studied in a slightly better population of patients in relapse 1. And what they did was post reinduction therapy or a salvage therapy with the R3 protocol. If they achieved less than 25% blast, they were randomized to continuing chemotherapy salvage versus randomization to 2 cycles of blinatumab. Here, it made a very significant impact. And as you can see, the overall survival in those who got blinatumab went up to 79% at 2 years, versus it was only 59% who got only conventional salvage. This is because blinatumab is really able to push the MRD negativity status from 21% to as high as 79%. So that is the real benefit of blinatumab in the relapse setting. It is able to push your MRD negativity, which has got a very definite impact on the outcome. So this concept has been used in the upfront setting. So this is an interesting study where patients in hematological response, but with MRD positivity, were given blinatumab up to 4 cycles, and patients could undergo allergenic transplant anytime whenever they were ready with the donor, etc. And the primary endpoint was MRD negativity after blinatumab, and you can see that 78% become MRD negative after 1 cycle of blinatumab. This is unimaginable just by giving intensive chemotherapy, and it stands to reason that these patients will do well when you do an allergenic transplant. MRD negative versus positive, as you can see, the relapse-free survival was 23 months versus 5 months. The overall survival was 39 months versus 12 months. So there were some adverse events, 13% grade 3-4 neurological events with blinatumab. But again, the survival benefit is very, very significant. Again, similar data from the Germans, which show that when compared to historical data, when you give blinatumab for MRD positive patients in CR1, the benefit was quite impressive. Quickly on inotuzumab, this is an antibody drug conjugate. The important toxicity is veno-occlusive disease. So an alternative dosing has been tried of 0.5 mg per meter square from the 0.8 milligram per meter square. Again, the impact here is in converting MRD positivity to MRD negativity as high as 78% in phase 2 studies. So the landmark study for this is the phase 3 study, the INNOVATE study, where in relapsed patients, inotuzumab versus physician's choice, the impact, again, 2-year overall survival 23% versus 10%. Doesn't look extremely impressive at this point, but remember, again, this is very bad subgroup of patients. This is the curve with inotuzumab. I'm not showing the upfront data, but inotuzumab again has shown some very impressive early data when you take it to the upfront setting. Again, here the importance of MRD negativity. If you are MRD negativity, the survival is 14 months versus if you are positive, it is 7 months. Again, this shows that those who are MRD negative and who got a stem cell transplant in relapsed ALL within the INNOVATE study, your survival would go as high as 40%. CAR T cells, again, this is not the forum for detailed discussion. This is one more option which has shown very dramatic improvement of survival of of relapsed ALL. This is some very recent data on venetoclax when combined with something called navitoclax, which is also an apoptosis inhibitor, which also inhibits something called the BCL-XL. The problem with navitoclax, it cannot be used as a single agent because it's very toxic. So you reduce the doses and combine it with venetoclax. In this trial of very heavily pretreated acute lymphoblastic leukemia who were relapsed, they had a very impressive 49% CR and a duration of response of 9 months. So watch this space. These are going to be interesting drugs which are going to be available and which we eagerly look forward to, because at this point of time, I would say that in ALL, in adult ALL, you have only one chance. You treat it properly first step, because once they relapse, whatever you do with conventional therapies, even if you do an allergenic transplant, your survival is very, very, very dismal. So that is why it is important to see how we can access these newer drugs in the coming years, because this is what is going to make a difference in terms of the relapsed ALL. Again, briefly on elderly ALL, this is another very dismal group, as bad as the relapsed ALL. So upfront therapy of elderly ALL more than 60 years, the survival is around 10%. So this is data in various age groups. 60 to 65 is around 24%, 17%, 12% as you grow older. So very dismal data from the real world. The CR data, again, you can see the curves are at the rock bottom. And some difference may be there when you look at the population-based studies versus some of the clinical trials. So the population studies show 10%, 6 to 13% in various studies. If you just use palliative treatment, the median survival is only 7 months. But some of the more intense studies have shown survival can be as high as 15 to 20%. But again, still dismal. So who is this elderly? In the West, they described as more than 60 years. In India, maybe we should start thinking above 50. Some of them have a lot of comorbidities. So even somebody above 50 years who are not fit for giving any reasonable chemotherapy will fall into this age group, and you expect very poor survival. Why is it bad? It's poor tolerance to treatment, but it's also because of adverse disease biology. The pH positivity rate really goes up in some of the studies, as high as 50%. You have high incidence of pH like CRLF2 fusions have been commonly described. And these other adverse prognostic factors are also overrepresented in the elderly population. Some of the single institution studies have shown that you can still try and give intense protocols in these patients. But unfortunately, even when you try that, the 5-year survival is not extremely great. It's 20% by using hyper-CVAD in these regimens. But the induction mortality and the other TRMs are very, very high. That is 34% death in CR. Our UCAL had a few patients, 100 patients in the 55 to 65 year age group. And as you can see here, their survival was only 14%, even in the context of a clinical trial. Some people have tried pushing pediatric type regimens in older elderly, in the PETIMA group at least. The important thing here is the TRMs, as high as 28%, 21% in the context of a clinical trial. So you can imagine in an unselected real world population, it's almost impossible to think of pushing pediatric protocol, except in those who are like super fit patients. Even then, you have to be very wary of getting high TRMs. What is the way to go in a patient with elderly ALL? This is not an uncommon scenario. We keep getting patients who are over 60 years diagnosed with ALL. At this point of time, most of us just do some vinclozine, steroids, see how they can take it. We almost never give asparaginase. And most of it, the time we end up with palliation, they progress in 6 to 7 months, even though get a CR initially, and most of them die within 1 or 2 years. So one consideration is addition of rituximab. Probably you can improve some survival. There is one data from the GMAL that you get a survival of 23% in age more than 55 years with their traditional GMAL soft protocol by adding a rituximab. So this is one of the things which probably can be done without pushing toxicity too much. Definitely consider using a prephase instead of jumping straight away into chemotherapy. Some people have tried reducing the steroids to block of 7 days with some gaps to reduce the problems because of hyperglycemia and other steroid complications like infection. Asparaginase, most people avoid or try to use reduced doses. But what again stands out here is try and improve outcomes by incorporating newer agents. At least in the context of pH positive ALL, by adding chemotherapy plus imatinib, we already discussed this. You can improve survival, and low intensity chemotherapy with dasatinib, again, you can improve survival to some extent. So quite contrarily, a pH positive elderly ALL probably currently has a better chance of a long-term outcome compared to a pH negative elderly ALL because of the availability of TKIs. Newer agents definitely show promise. Again, data from MD Anderson, mini hyper-CVAD, which is a much toned down version of the hyper-CVAD without some of the toxic elements. With inotuzumab, they have showed a 2-year PFS as high as 59%. But again, MD Anderson data, it's a single center data, highly selected patients. So it may not be applicable in general practice, but again, interesting data. Again, people have used blinatumomab followed by some POM chemotherapy with just methotrexate, 6MP, prednisolone, and vincristine. Very soft type of therapy, shown overall survival at 1 year as high as 65%. So This may be the future for elderly ALL. Incorporate these newer drugs, reduce your overall chemotherapy intensity, and this will probably definitely improve the outcomes. To summarize, very poor outcomes from conventional therapy. However, a fit patient, remember, is better treated with some proper protocol and has a very small chance of good outcome rather than just putting him on some kind of a palliation. So whenever possible, try to do at least some reasonable protocol for these patients. In single institution studies or clinical trial, you can deliver intense protocol in elderly, but again, remember significant toxicity and very high TRM. Even in clinical trials, 1/3 can die because of toxicity. So the way to go in future will be the newer drugs, but at this point of time, we do not have access to these. So coming to the last part, the take-home points. An adult ALL has got huge variation in presentation. So the therapy has to be tailored based on multiple factors: age, comorbidities, the phenotype, if you have a mixed phenotype, pH positivity, the molecular biology, the MRD status, whether you can access newer drugs or not. So various considerations go. There is no one-size-fits-all approach for an adult ALL. Roughly go with for a pH negative ALL, whether it's B or T, roughly you go with a pediatric type protocol for a younger person. If they are MRD negative, continue the protocol. MRD positive, if you have a match, go for an allergenic transplant. So this is the broad way to go. In the Western countries, if they are MRD positive, they try to give some blinatumab and then go for allergenic transplant, because this really pushes up your MRD negativity rate. Remember, when you take somebody for allergenic transplant, if they are MRD negative, they do much better than somebody who is MRD positive at the time of going for a transplant. So you try to get some MRD negativity prior to transplant, either with some intensive chemotherapy or blinatumab whenever possible. pH positive ALL, low intensive therapy with steroids, get a remission, and then continue either intensive therapy or an allergenic transplant whenever a match is available. How to improve therapy? We already discussed about using pediatric protocols whenever positive. Whenever possible, you can push up to 50 years of age if you're comfortable. Again, managing toxicity in the adults. Pulsed dexamethasone is one of the strategies which has come out, which reduces the toxicity but maintains the efficacy. There are some studies which have tried to do elasparaginase dosing based on the pharmacokinetics, and this is shown to reduce the hepatotoxicity. These are some of the newer strategies which are coming up. There are some interesting pharmacogenomic data which shows that vincristine neuropathy is overrepresented when they have some types of SNPs in the CEP72 promoter. So this may come up in future, and in these patients, you can safely reduce vincristine doses without compromising the efficacy. Again, this is an interesting data from TMH, which showed that by using prophylactic bisphosphonates at very low doses, you can significantly reduce the incidence of avascular necrosis. So again, these are simple things which we can consider when you're using pediatric protocols in adults. Other things which are doable in India, like rituximab, should be considered whenever possible for CD20 positive ALL. And MRD, if you have access to MRD and allogenic transplant, consider for the high-risk patients. Not feasible at this point. It's not possible to use nelarabine for all the TALLs, blinatumab, inotuzumab, CAR T cells. These are the future. When we get access, definitely we should use that. Challenges due to bad biology are not modifiable at this point, but again, attempts to understand will help us in future therapy. So try to classify in your center, especially if you're an academic center, try to see how many of them are ATP ALL, what is the proportion of pH like ALL. So these are important data we should try and generate. Pharmacogenomic data is hardly available from our country, which can help us to improve outcomes at least in the future. Again, not to forget, when you're treating adults, importance of adherence, importance of treatment completion, importance of psychosocial issues. Social support whenever possible. Provide, you have home away from home for pediatric patients. There is no such support for AYA patients. They have educational, vocational issues which make them default on their therapies. Important psychological support for women, especially WIGs, peer group-based counseling sessions really help. These are all adapted from the pediatric approaches, but again, important even in the adults. Financial support. There are many groups supporting pediatric ALL, very little for an adult. Survivorship challenges, completion of education, repayment of fees, employment loss, discrimination when they go for re-employment, marriage issues. All these issues come into play important to have a big group, have a social worker, have a psycho-oncologist, have a big group for dealing with this. It's not possible for an oncologist alone to do a good job in managing an acute lymphoblastic leukemia patient. Well, stop here. It's been a long talk. Try to cover as much as possible. I'm sorry, I've really gone past the time allotted, but I'll be happy to take questions at this point of time.
It was really an exhaustive overview, Prasanth. Wonderfully covered the topic. I think we won't be able to take a lot of questions. I think we have you have the questions in front of you in the chat box. We can take probably a couple of them, and maybe some other time. You can choose which you think we probably
We'll just take few questions.
Yeah.
Can we completely avoid prophylactic cranial radiation in adult when you use a pediatric protocol? If you're strictly using a pediatric protocol, yes, you can avoid PCI because you will apply the protocol as such, and that's how many of the groups have done. So they have not brought in PCI. You use the protocol as such, so you don't try and give PCI if the protocol does not mandate a PCI. Which MRD timing to consider for transplant? So most people consider the end of 4 weeks of induction MRD as the standard of care. Some groups have used it at the end of 8 weeks. So this is really variable. But any MRD positivity within the first 3 months should be considered as high risk and should trigger an allogenic transplant whenever feasible. Arbitrary age for giving pediatric and adult protocol, as I mentioned, it should be tailored according to your comfort level. So when you're starting first time with the intensive protocol, go up to 30 years. As you grow more comfortable, you can push it up to 40. I would be comfortable pushing something like a BFM protocol even up to 45 to 50 years if the patient is fit, does not have too many comorbidities. So really tailored. So would you, for MRD positive, would you intensify the chemo, turn the patient MRD negative and take him for allogenic transplant? Ideally, yes. There are no randomized trial for this. But generally what happens is you still need some time before you go for an allogenic transplant. So within that time, you can try some more high intensity protocol like an augmented BFM, something which is more intense than your traditional thing what you're doing. Try to get them into an MRD negativity and then go for allogenic transplant. Maintain intensity or accomplish the whole treatment in time. So intensity is a factor of both the chemotherapy doses as well as the time. So when you tell dose intensity, it means the time also. So you should try to achieve the entire thing within the time. So the question, I'm not very sure whether I really understood. So whether time versus intensity, I think both are important. You should get the doses within a certain time. So dose intensity incorporates the time also. The next question is, I'm just skipping some of the questions. We did not talk about MPAL. So MPAL is currently mostly treated like ALL, but generally I would try to consider for an allogenic transplant for patients with MPAL. Would you modify or omit L-asparaginase in adult ALL? No, I do not omit L-asparaginase in at least in AYA ALL because I use a pediatric type protocol. But in somebody who is above 40 years or maybe above 50 years, definitely I reduce or omit L-asparaginase in some of the patients. MRD positive, how would you approach given the patient was standard risk to start? If MRD is positive, it doesn't matter what risk group you started off with. If MRD is positive, you still consider it as high risk and try to do an allogenic transplant, especially if they have a matched donor. I did not go into details on supportive care, antifungal, etc. But for this question, whether you should use antifungals in ALL, so it depends on your center to center consideration. If the risk of fungal infection in your center is low, you can probably get away with something like fluconazole prophylaxis. But in your center, if you routinely encounter like aspergillus during inductions, definitely you should go for a more much better prophylaxis with either voriconazole or something like a low-dose amphotericin B or a posaconazole. But again, remember when you're using all these azoles like voriconazole, you have to be wary of drug interaction with something like vincristine, etc. So yes, I generally use voriconazole prophylaxis because I find whenever you use only fluconazole, you have higher chances of getting into infections. In CVT, will you replace elasparaginase with any other drug, or will you happy with that? The current pediatric protocols say that if just because somebody got a CVT, you do not have to omit the elasparaginase. If the CVT is well managed, he is continuing on something like low molecular heparin, you can re-challenge with elasparaginase. This is a concept in pediatric protocols. But yes, you have to be cautious. Sometimes you get into trouble. We recently had a patient where we re-challenged with elasparaginase during the consolidation phase, and the CVT recurred. So there is a problem there. But yes, if you strictly go by the pediatric recommendations, you can re-challenge with elasparaginase in a patient who developed CVT. A patient presenting with CNS hemorrhage at presentation should be treated as having CNS disease. Yes, probably. Yes, we should give some extra consideration for CNS prophylaxis. Can we re-challenge elasparaginase? That question we already answered. Why pH positivity go away early in ALL cases but not in CML-CP? I think that is a very good question. Probably maybe you are using not just maybe you're using a lot of chemotherapy, and that is probably the reason that you're getting more negativity in ALL compared to CML-CP. I'm just guessing. I do not know. That's a very good question. Why does pH positivity? Why do you get a CMR very early in ALL, but you do not get it in CML-CP? I do not know the answer to that. Which patient will you consider for craniospinal radiation even after using high-dose methotrexate? So many of the adult protocols and even the BFM or older versions of the BFM protocol used cranial irradiation even after using high-dose methotrexate. So if you're using, it depends on what protocol you're using. So you follow the protocol. So if you're using a very modern COG protocol, there is no CSI in that if you're using high-dose methotrexate. But some of the older protocols used that. So in adult patients, we generally use an older BFM version where we still use CSI for our adult patient even after using high-dose methotrexate. So it depends on protocol to protocol. For pH positive ALL, even if transplant is not feasible, you prefer TKI with low intensity chemotherapy, or should we intensify chemotherapy to get? So remember, in a pH positive ALL, if you are not doing allogenic transplant, after induction, you must consider regular standard intense chemotherapy as per the protocol along with the TKIs. Only if you are doing transplant, then you are getting away with less intensity chemotherapy. But in induction, the GRAL protocol has shown that as far as the induction is concerned, you can get away with only vincristine, steroids, and TKI, and you get similar results. But after the induction, you must continue intensive protocol. TKI of choice in pH positive ALL at this point, it would be dasatinib, because cross-trial comparisons show that at least the MRD negativity rates are higher with dasatinib as compared to imatinib. And at this point of time, we have similar cost for dasatinib and imatinib. So I would prefer dasatinib for pH positive ALL. Do you start TKI upfront in pH positive ALL or wait for count recovery? No. Clear data showed that from multiple studies, the TKI should be started as soon as possible, as soon as we know the pH positivity. In some of the, you can, if there is a severe myelosuppression, you can probably temporarily hold the TKI during therapy, but it is important to start it as soon as you get the diagnosis of pH positivity. It should not be it should not wait till count recovery and then you give the TKI. No. pH positive induction, which regimen do you choose before allogenic? When patient hasn't achieved CR post phase 2 induction before allogenic transplant. Oh, okay. So as I showed, somebody who has not achieved CR after 2 courses of induction, phase 1 and phase 2, have a very dismal prognosis. Generally, what you would try and do is something like a flag IDA, get them into a remission, and then go for allogenic transplant. But remember, this subgroup has got a very poor outcome. So ideally, they should probably get one of the newer drugs and then get an MRD negative and then for a transplant. How to approach when discordance between MRD and CR status, post-induction MRD negative, but bone marrow not in complete remission. So you get that very rarely. I think sometimes what happens is the bone marrow is not in remission, maybe because of some kind of hematogones. So I think you should discuss with the pathologist in detail and relook at the morphology again. And I think the MRD actually scores over the morphology in this context. So you have to take it as MRD negative, you take it as remission MRD negative. I think that's all. I think we try to cover all the questions very fast. If I missed something, I'm really apologize for that. Dr. Padmaj, over to you.
Yeah, thank you very much, Prasanth. I think it was very exhaustive coverage. You must have been tired. I mean, you've been
No,
preparing hard. Yeah, preparing hard for this. I'm looking forward to having you write that how I treat series for IGMPU, and I think all students will benefit from that as well. Thank you very much for being with us, and we look forward to having you sometime in future again. Thank you very much.
Thank you very much. Thank you very much for the opportunity. Thank you.